Okay, I'm just going to talk a few minutes on mitral regurgitation. This was supposed to be after AVSD yesterday, but it's part of the mitral valve. A lot is repetition of what we talked about in aortic regurgitation yesterday. So it's just a repetition of the same principles, really. The numbers I'm going to show you in the studies are done by the same people, actually. They look similar, but believe me, it's mitral regurgitation, not aortic regurgitation. So here's left AV valve regurgitation after AVSD. I already showed you that inflow velocities are related to pressure differences between the atrium and the ventricle, while tissue Doppler velocities are related to the volume changes. And so that's going to change or influence how we see these when you have an increased preload. So if you look at regurgitant volume in mitral regurgitation, this is very similar to what I showed you for aortic regurgitation, and you look at the end diastolic dimension, as your regurgitant volume goes up, your end diastolic and systolic dimensions go up. That's not surprising, particularly this is adult data. And if you then look at your E velocity, right, which we said was a pressure gradient really, or influenced by the pressure gradient, then here's the control, and as you get more severe, the E velocity increases. In fact, some people will say that if you don't have an increased E wave velocity, you don't have severe mitral regurgitation for that reason. So when you're trying to assess severity of regurgitation, and I'm not going to go into that at all, you have to use multiple criteria. That can be one of them, an adjunct to help you judge. But you can see that if I told you for aortic stenosis that mitral systolic ring displacement in the longitudinal direction was helpful, you can see that between the controls, the mild, moderate, and severe, it wasn't particularly helpful, and there wasn't any statistically significant differences, and very little absolute differences, if at all. So here's the septal mitral ring, and here's the velocities. Here again, they've divided their regurgitant volume up by a certain cutoff and decided who's mild, moderate, and severe. And then here in these gray bars are the normal areas of systolic velocities for the septal and lateral ring. And you can see that if you are mild or moderate, generally you are in normal values, except for a few patients. But when you get to the severe regurgitation, there is a scatter. Some are more than or supranormal, some are within normal, and some are less than normal. And it's very difficult to judge what is a volume effect, because you're with velocities, what's the volume effect, and what's truly a reduction in contractility. Because just like we spoke for yesterday, for the aortic regurgitation, you want to catch the ventricle and intervene at a time where you can reverse that vicious cycle of ventricular enlargement, increased wall stress, increased contractility, etc., and I'll show you that. So those were the velocities, but if you look at the strain and you look at the LV lateral wall, and this is strain rate and this is strain, so just to make it easier on us, not to strain us too much at this late stage, here is the controls, 21, mild, moderate, you can see that strain is preserved generally, and that's adaptation, and severe is already decreased strain. So already beginning to see effects of that over there. Just remember that, don't think what it means at the moment. I've shown you this at least twice, because as the mitral regurgitation happens, we said that the ventricle initially will do two things. It will dilate and will increase contractility if it can. And why does it do that? It does that to keep the stroke volume, because it wants to supply blood to the body. It's now that same left ventricle has to pump blood back into the left atrium, because it's mitral regurgitation. It's got to pump blood forward to the body to supply the tissues. So it does that by increasing its end diastolic diameter, and you can see that as you increase that, your stroke volume goes up for any given contractility. These are isocontractility lines. It can also do that by increasing the contractility itself and jumping up on these curves to increase the stroke volume. And I told you yesterday that if you keep your contractility the same and you increase your end diastolic diameter, you can then decrease your deformation to achieve the same stroke volume. So this is the compensation of the ventricle. Increase its diameter and increase its contractility. So when you see preserved strain, you don't know if it's because just the end diastolic diameter has increased, or if it's also increased its contractility, or what's at play here, and if the ventricle is able to do that. So we asked the question in aortic regurgitation, and it looks exactly the same graphs, but this is for mitral regurgitation, and it's the same group, Anna Marciniak from the Leuven group. And you can ask the question, well, should we correct strain and strain rate for ventricular size or volume? This is the uncorrected strain rate, and here's strain. And again, you can see, just like in the velocities, although it's a bit more sensitive, that the mild and moderate generally are in the same range, and the severe, some are below the normal range for strain, and some are within the normal range. So who has normal contractility, or who should we go to an operation with before that ventricle starts to decompensate? So here are the corrected values for end diastolic volume. So end systolic strain corrected for end diastolic volume, and this is the regurgitation severity, the regurgitant volume. And now you can see a similar picture, but this is tightened up a lot more, because you can see that again, those that are mild and moderate, hardly anyone has abnormal relations of or decreased strain, if you will, below this cutoff. But now you can see that those severe patients, there are a few that are normal, but things have tightened up. And if I just place the previous slide a minute, you can see how that has tightened up. So looking at this in a similar way, if the guidelines, and this is from a few years ago, I think there was some update in the guidelines, but the principle is that the guidelines say that if you have an end systolic dimension of above 4.5 centimeters in adults, then you should go for surgery. So if you don't correct for ventricular volume, then many patients have abnormal values despite them being mild or moderate. But if you correct and this is the strain versus that, if you correct for size, you can then pretty much pick out those patients that have decreased deformation and really do need that surgery. So can we use these methods to then predict who's going to do okay after surgery? And again, we've talked about using exercise to predict who is going to respond. And to cut a long story short, you can see that the end systolic volume, and this is an older paper, so they're not looking at strain, the end systolic volume indexed correlates quite well with post-operative LV ejection fraction, and the end systolic volume index during exercise, this is this graph, this curve over here on the ROC curve, best predicts who's going to have an LVEF of above 50, which they defined as normal after surgery. So again, using exercise to tell us what our functional reserve is. You can use strain and strain rate now, this is later, this is this year, to do that, because if you look at the EF across groups, and I'll go into the groups because it's important. So group 1 are those with a post-operative EF of above 50 at 1 year follow-up. Group 2 is those with a decreased EF at follow-up. Those are the group you don't want after AVR to have a decreased ejection fraction. Those are patients you come to too late. But you can divide this group, or they divided this group into two. One is 2A, which were asymptomatic or minimally symptomatic patients, New York Heart Association 1 and 2. And group 2B are severely symptomatic patients that initially had a good ejection fraction and deteriorated after surgery. So if you look between these two groups, you'll see that group 1, which is defined by the ejection fraction, are minimally symptomatic before surgery, have a good EF. Group 2B have a reduced EF. Those are obvious who has to go to surgery. But group 2A has a normal EF. So it's very difficult to differentiate between those patients and see who needs to go to surgery. So if you look at the EF of these groups after surgery, those that had a reduced EF after surgery for the mitral valve, their EF did not improve. Those that had a good EF, the group 1, who had a good EF before surgery, they had an initial decrease following the surgery itself that's not unexpected, and they recovered their function and kept their function. But look what happened to that group 2A over here. They had the same decrease, but they never recovered their EF, and that's why they went into group 2 in the first place by that separation. So it's really this group that you're going to try and get at, and you can't get at them by pre-op EF. Maybe you can do it with exercise, but you can't do it just by looking at their resting EF. Now we know that strain and strain rate will correlate with the EF, but still, if you look at their EF, at their strain and strain rate before surgery and then in the 12 months of follow-up, and you can look at group 2A, there's a clear differentiation where the ejection fraction had failed to find that. So this is probably, or maybe, this is very early data and hasn't become routine and needs to be validated, but this may be one way to differentiate those patients and see how the ventricle, how the deformation corrected for the geometry, for the preload essentially, is functioning and who needs surgery. So I'm going to stop over there, and I don't know if it's a break now or a break later. It's a break now. I'm always happy to lead to the break. Okay.
We'll convene in 15 minutes.